there seems to be a loss of this layering. This spongiosa part seems to be thickened.
Yeah.
So this would fit a degenerative mitral valve disease or also tricuspid.
Sure. So, say again the name of the histological diagnosis, because I didn't list it well. I'm sorry, Claudia.
Degenerative mitral valve disease.
Which kind of degeneration? Because if you say myxomatose degeneration, that's the key word. Myxomatose degeneration. And do you know what means myxomatose? The name myxomatose. Myxomatose means a type of tissues, is a mesenchymal tissues, connective tissues characterized by spindle cells with abundant interatrial matrix. And in the matrix, there are some important molecules like glycosaminoglycans that take the fluid. And that's because the degeneration induces a floppy situation. Because in these tissues, in myxomatous tissues, in the matrix, between the cells, because in all the connective tissues, we have cells and matrix. The cells are elongated, and the matrix is very abundant. Claudia, did you understand me?
Sorry, the matrix is?
Yeah, here the matrix we cannot to see because the field is not the best. We have to use a much more power field. But the field is more or less the pink area.
Yeah.
And of course, this kind of field is not the best. Here we need to appreciate also some kind of evolution of the disease, because the myxomatose degeneration start in the ending of the leaflet, more or less here, and which the time grow from the basic portion of the leaflet, so closer to the ring, and now almost half of the leaflet have the degeneration. What about this kind of structure? Claudia, what do you think?
This could be a part of the chordae tendineae.
That's correct. And look, that's correct. And look here, for example. For you, is it normal or abnormal?
It's also thickened and
Sure.
abnormal.
Sure, that's abnormal. That's thick because there is a myxomatose degeneration.
Yeah.
Also here. And that's because there is the rupture of the chordae tendineae. In the previous case, we look with Joao, the rupture of the chordae tendineae, for example. And that's because also the chordae tendineae in the chronic, in the very chronic stage of the disease have the myxomatose degeneration. But start here. And then with the time, grow in this direction. And Claudia, why start here the degeneration?
Because there are more shear forces.
Yeah, because of the coaptation.
It's the area. Yeah.
Yeah, because there is much more coaptation of the leaflet. And so
Yeah.
we know that for the pathogenesis of this very important common disease for us is because there is a genetic basis, but also a mechanical component, stress, very chronic all the life. Every time there is the coaptation, there is a activation of the interstitial cells. That's summarizing the pathogenesis that is very, very complicated. Claudia, Do you understand me? Do you listen?
Yeah, I understand. Thank you very much.
Okay. Other question? Everything is clear?
Uh, Massimiliano, if we have a picture like this in the exam, and if you see that there is a rupture or what it looks a rupture of a chordae tendineae, we should comment on that. We cannot assume that could be because of of the preparation of the slide that looks ruptured but is not ruptured. We can say that is ruptured, right?
No, for me, it's not possible to say rupture at histological examination, Joao.
Okay, so that's good to know.
Yeah. It's possible only at the gross examination. Why is not possible at the histological examination? Because it's very, very hard to put in the same slides all the chordae tendineae.
Yeah.
So
Okay.
you have to put the space between in the same chordae tendineae between the leaflet and the papillary muscle. Come on, it's very difficult. Also because the chordae tendineae is branching structure. It's not possible to put. It's very. I think it's almost impossible to put in.
No, I understand that. It makes completely sense. It's just to make sure that we shouldn't comment on that. We just really to just make sure. That's fine. Thank you.
Maybe I can ask it to you for the examination. What do you think about the chordae tendineae? Of course, there is thickening because of the degeneration. What can induce this kind of finding? Can induce the rupture.
Yeah.
Could be
Okay. Okay. Thank you.
Oh, that's a joke. That's a joke. It's not. Take your time. We want to try. We have two different dogs. Of course, 3 pictures, but 2 photos, 2 pictures are from the same case. And so between the 2 pictures, there is a link.
I can do it if you want, guys, or if anyone wants to go ahead.
For me, it's okay. For me, it's the same. For me, it's the same.
No. I can hear someone trying to talk.
Sure. If you want, Jonathan, if Frader is okay, for me it's okay.
This is Mattia, but I'm happy. Can you hear me?
Okay, Mattia, it's your turn. Okay.
Okay, I'll go for this. Okay, so we've got 3 gross pathological images. The first one, A, we are looking at a view that shows us the inner face of a great vessel, an artery. Consider the size of the wall. Inside the vessel, we can identify a structure that looks like a, let's say, a mass.
Mattia, I'm sorry. Can I say something?
Yeah.
Because I agree with you. That's an artery, but
Yes.
here we see also another structure.
The structure below, I believe it's a ventricle.
Sure. So what
ventricle.
are we looking for?
What do you mean? Sorry.
So we are looking for a ventricle and an artery, and so
Yes.
we are looking.
We can be either right or left side, and I think it's gonna be right side.
I didn't listen. Say again.
I think it's gonna be a right side.
Right side.
I will go for that based on those trabeculae over there. Yeah.
Look here, for example, one and the other. Look here.
Yeah.
I cut this structure.
Yeah.
before to see.
Okay. So I don't really get it. So you mean you cut through the septum, therefore this is not the right, or I don't get it. I lost you.
Okay,
Hello?
that's an outflow tract, of course. That's clear. I think
Okay.
I think it's clear because I look
Yeah.
an artery and I look a myocardial wall, and I look something in the middle.
Yeah. And so I was talking about those trabeculi down there. I thought that that was the right ventricle due to that.
No, that's not a real trabecula.
Okay.
But of course, look
So,
here, for example, Mattia, sorry, look here and here. If you think about the structure, is that before it was the same anatomical structure here and here.
yes, so it was the origin of whatever vessel it was. So either the aortic base, so the outflow tract
Okay,
of
so
the right.
that's the left outflow tract, and
Okay.
before to see, I have to cut in a longitudinal point of view. I have to cut the anterior leaflet of the mitral valve.
Okay.
So ascending aorta,
Okay. Yes.
ventricular wall, that's the interventricular wall in particular, anterior or aortic or septal leaflet of the mitral valve that I have to cut before to see what? What I'm looking here?
You're looking at the aortic valve.
The aortic valve, sure. For you, it's normal or abnormal? Of course,
It's abnormal.
sure, abnormal. And why it's abnormal?
It's abnormal because it's, I think, also thickened, but most importantly, there is a nodule or a mass on its dorsal surface, so the aortic surface, that is a dark brown, large, I would say, occupying probably half of the lumen, and it's also proliferative in a region of it.
Look here, for
And
example. I'm sorry, Mattia.
yeah,
Look here. That's a piece of blood. That's a clot. But look here.
yeah, that's kind of a more proliferative, pale, nodular proliferation.
Okay, that's a esophytic endocardial proliferation.
Yeah.
Okay. Look in the other picture.
Yes.
Of course, you know this kind of diagnosis now.
Yeah, I would say it's compatible with an endocarditis of the aortic valve.
Perfect. Okay. And now find the link.
So the link between A and B?
No, between A or B or C.
Okay. So, I mean, if I force my imagination, I could probably find a link between all of them. But let's.
For the fantasy, that's
Okay.
nice.
So I think that if with the picture C, I guess it could be compatible if we do have a concomitant presence of a sepsis, for example, inducing both myocarditis and endocarditis.
Because sorry, Mattia, but what do you think? What do you see in C that is
Yes, I described it.
that can to represent a link with A?
Yes, I will describe that. So I think we've got a cross-sectional cut of what it looked like a ventricular section, towards the more or less apex, papillary muscles apex. We do have a region of this left ventricle that is discolored with a brown-red pigmentation that starts from the endocardial surface and goes towards the epicardium, affecting roughly half of the thickness of the wall. It's moderately extended, and again, it starts from the inner side, going outside towards the epicardium. So to me, that could be compatible with an infectious disease. So it could be an infectious process starting from the endocardial surface, compatible with, let's say, a myocarditis. It could be an infiltrative disease, let's say neoplastic, a bit less likely, I think. And it's less likely to be a vascular event such as an infarct, because it doesn't have a conical shape. It doesn't come from the outer towards the inner side, so it would be, to me, less likely. So infectious would be more likely, and if I have to find a connection between the focus of myocarditis with the presence of endocarditis of the aortic valve, I could think of sepsis or a severe process that affects the heart. Anyway, most likely, as I said, it's going to be widespread.
Yeah, that's the main focus, of course. There is a endocarditis, aortic endocarditis, and so there is an involvement of Valsalva sinus, and so an embolism of septic embolic in the myocardium. That's a septic infarct, of course.
Okay, nice. I missed the infarct a bit.
Yeah, but you told the infarct, necrotic ischemic process, and why not in the middle the B? Which is the B?
So in the B, we can see first of all the elephants, or better, the worms. So there are long, circular, rounded, transparent, whitish parasites that they are compatible with, I guess, Dirophilarias immitis, or at least they look like that. And
where we are here.
So we are at the base of the heart. We've got an open artery that is what I believe it is the pulmonary artery in this case.
But here it is not heart here.
That's, I guess, it's the lung.
That's lung, sure. That's of course, a branch of the pulmonary artery in close to the lung, sure.
Yeah, and then we do have, let's say, a proliferative appearance of the inner face of the endothelium of the pulmonary artery. That looks nodular. Nodular looks, yes, irregular.
Granular, maybe better. Granular appearance, yeah. Irregular, small.
With inflammation. So I would expect obviously these lesions, they could also, this disease, the Dirophilariasis, could also lead to thromboembolic disease, though the circulation would lead first to pulmonary thromboembolism rather than coronary thromboembolism. Therefore, it's less likely.
Yeah. And of course, basically, the link in this specific case is between the A and C. B is another history.
Okay.
Is it clear for everybody? For anybody? Is clear?
Yes, yeah. Massimiliano. Can I just double check something on the image of B? Can we say for sure from this image which artery it is, or can we just assume that it's a pulmonary artery because it's quite close or surrounding the lungs, but we cannot say which one it is? Is that correct? Isn't it?
Yeah, is it correct for me? Because I kind to see the correct anatomy of the pulmonary artery.
Okay, perfect.
I can't see it's a pulmonary artery, but
I've also got a question, actually 2 questions that I forgot to ask
Yeah.
very quickly. The first one is, do you think that this C section, the C picture, is it slightly hypertrophied on the opposite wall to the infarction?
Okay, from the picture A, we cannot to say there is hypertrophy, but we may to say in C, yes.
Okay.
Yes, that's interesting because aortic endocarditis, if it's a proliferative process, can induce some kind of acquired stenosis, can induce something, or if it's an ulcerative process, can induce an insufficiency of the valve.
Perfect.
But also, also that in the chronic situation, in afterload mismatch, it could be also a dilatation in case of hypertrophy, in very, very chronic evolution.
Perfect. And the other question was, I know that usually infarctions or ischemic disease and the myocardium, they have this triangular shape. Am I right?
No, triangular shape is usually in the kidney.
Okay, I'm totally wrong. Okay.
No, not the myocardium. And that's because in the kidney there is a particular type of vessel.
Yeah,
Usually in the myocardium is not so characteristic the shape of the ischemia, of the infarct. Usually we see the difference of color. Sometimes it's irregular, small, larger, so it doesn't matter. But in the kidney, usually it's very triangle with the apex closer to the medulla.
Perfect, okay.
Other question?
Yes, Massimiliano, sorry, Alessia.
Okay, Alessia.
As Jonathan has some problem, he wrote a question. For B, would you say endarteritis because of the irregular aspect of the endothelium?
Good question. If I look at the histology, maybe there is inflammation. Yeah, is it correct? It could be, but I need the histology. But for a speculation point of view, it's possible because there is a reaction of the endothelial layer, and it's clear because there is a diffuse granular appearance, granular thickening, and of course, if there is a mechanical reaction, I'm sure there is also leukocyte infiltration. So, is it correct? But with histological presentation is better. Is it okay? Good. Another one. Uh-oh. Who want to try?
I'm happy to try.
Sure.
So we have 2 sections of myocardium. Is this the Mason's trichrome stain?
Yeah.
So the sort of red is myocardium. The more blue is more collagenous or or fibrous tissue. And
I'm sorry. Do you remember the name of the stain?
Is it Mason's trichrome?
Yeah. Mason's trichrome. That's correct.
And white is fat adipocytes. So I think the myocardium, the myocardial tissue is sort of it's interrupted. Its arrangement is interrupted by the fibrous and the fatty tissue.
I'm sorry. You are speaking about the left or the right picture?
Oh, sorry. I should have specified. The right, it's more clear because you can. The right is on the right. You can see the arrangement of the myofibers, but with this interruption with adipocytes and fibrous tissue.
Yeah.
The left, you can see that there's a much more significant infiltration and replacement with fibrous and fatty tissue, and only a small amount of myocardium is left.
Yeah.
So I think I would imagine these findings are most suggestive of arrhythmogenic right ventricular cardiomyopathy with fibrofatty infiltration.
Okay, say better because we need it to be clear. So now we are speaking about the left picture. That's correct?
Yes.
Perfect. And of course, I agree with you. I think it's clear now because there is a transmural fatty and fibrofatty because there is blue area with Masson stain. There is a fibrofatty, severe fibrofatty replacement. So we see just a small portion of the myocardium here. And in the opposite, the right picture, could you please repeat the main histological finding?
So the normal arrangement of the myocardial cells is interrupted by fibrous and fatty tissue.
Yeah, but what about the fat tissue? It is not like the picture on the left side, of course. It's clear, I think.
Do you mean the orientation is different?
Oh, not the orientation, because now the most important find is the quantity, how adipose tissue there is.
Oh, okay. So because in the left image, it's nearly all replaced, whereas in the right image, there's still quite a lot of normal myocardium.
Yeah, there are a multifocal group of adipocytes.
Okay.
And of course, there is also multifocal small interstitial fibrosis. And of course, there is also myocardial bundles. I think it's clear. So, what I want to mean, what the right and what the left, because in both pictures we are looking the ventricular wall. Of course, here we see better the situation transmurally from endo to epicardium. And here we are, but which is the right, which is the left? So, do you understand the question?
Do you mean which is the right ventricle, or?
Yeah, which is the right ventricle and which is the left ventricle?
The image on the left is the right ventricle.
Sure. And the diagnosis is?
AR. Arrhythmogenic right ventricular cardiomyopathy.
Sure. And on the left, what's happening?
It's. I mean, can you also have the same processes affecting the left ventricle?
Why not? But I have to say also in the left ventricle this kind of finding. And so it's possible to see also in the atrium. It's not very common, but there are some papers that describe in the atrium arrhythmogenic cardiomyopathy with fibrofatty infiltration. But we know also, we spoke yesterday about in dog, not in the right usually, but in the left ventricle, kind of histological phenotype in case of?
Oh.
Do you remember?
I'm not sure. Sorry. I mean, it could be
A kind of cardiomyopathy.
I mean, the only one I could guess would be dilated cardiomyopathy.
That's correct. That's correct. That's a fibrofatty type of dilatative cardiomyopathy in dog.
Okay, thank you.
Okay, and that's the correct presentation. Of course.
Emiliano, can you hear me?
Fabio, say more.
I just want to ask, so the main difference basically is,
Yeah.
I just got lost because I need to change the microphone, but the main difference between the two pictures is the amount of fibrofactor infiltration, is that right?
It's correct.
So in DCM, we are looking for something less obvious as it is in the left picture, I guess.
Yeah. In the RVC, you have to see transmurally the wall.
Okay.
Transmurally.
Okay.
And that's because for me the correct presentation is medium power of field. So, but if I put the same power of field for the right picture, you see a multifocal group of adipocytes.
And in the picture on the
Fabio,
right,
Fabio,
can you...
is it? Sure.
Yes,
Okay.
it's clear. Thank you, Massimiliano.
Okay.
I was just wondering, another quick question. In
Yeah.
the DCM picture,
Sure.
we don't see the wavy
No,
fiber in this case, no.
no.
I guess
no.
is that because it's a cross section?
No, because there is another type of histological
Oh,
presentation.
so it's just a completely different type. Okay.
Yeah, do you remember there is type of boxer, type of Doberman, something like
yeah.
that?
So in the type, I thought that in this type you also have fibrofactor infiltration on top of the wavy fiber, but no,
Yeah.
it's just a fibrofactor infiltration. Okay,
Yeah, just only fibrofatty infiltration.
that's interesting.
In my experience, but I not a lot of cases of DCM in dog. I much more cases in hypertrophic cardiomyopathy in cat. So dilated cardiomyopathy in dog primarily is for me, unfortunately, is not so frequently. But in my experience, if I see wavy fiber, I don't see the fibrofatty type.
Okay. Yeah, no, to be honest, I remember in Ettinger as well, they mentioned this microscopic representation of DCM with fibrofactor infiltration. I can't remember whether they said it goes together or not, but definitely, yeah. Thank you.
Yeah. Other question?
Massimiliano, can I just ask a quick question, if you don't mind, about just the right terms that we could use in an exam situation? So obviously, on the left picture, we have a transmural, and we can say that is a replacement, right? Replacement fiber of fatty replacement that occurs transmurally. But on the right one, can we still use? Should we use interstitial, or should we say replacement?
Oh, that's a good question. That's a good semantic question. Also in the right, the adipocytes replace the myocardial layer, the myocardial cells. And
Sorry, can you repeat again?
Also in the right side there is a replacement.
On the right side is also replacement. Yes. Okay.
Yeah. Because if you see adipocytes, of course you don't see the myocardial cells.
Yeah.
And
so they are replacing the myocardial cells that were there before.
But the severity, of course, is different.
Yeah. Okay. Thank you.
Yeah. Other question?
May I ask one question?
Sure.
Maybe I'm wrong, but I can remember badly that in this type of DCM with fibrofatty replacement, the biggest amount of fatty cells is close to the epicardium.
I've noticed that. I've noticed this.
Maybe I'm wrong. I just have in my head that it was something going from one direction to the other, like starting from epicardium to endocardium, or the opposite. I can't remember. Or maybe
It's a good question. I have to check, Ursula. Thank you. I have to read the paper and the description. In my experience, is random. I don't remember a specific distribution.
No. Probably I'm absolutely wrong if you don't have this in
No.
your...
In case of DCM with fibrofatty presentation, I don't remember a specific type of distribution. I don't remember, but I have to check. Is a good question, of course. I don't remember.
I think probably Claudia knows better than me, but I think Irish wolfhounds can get these changes in with the CM phenotype clinically, and then they can, on histopathology, they can get this fibrofatty as well. I think a paper that I think was published by her. I'm not sure, but I think it was by her.
In the atria.
In the atria, and I was just checking now that and the ventricles as well, or just in the atria.
Well, it depends, but in some dogs it was just in the atria, and in some dogs it was in both. But in those dogs with lone atrial fibrillation, there were some dogs where it was just in the atria.
Yeah. At the moment, I'm listening to your abstract, to be honest.
If you want, Guy, send to us the paper so we may to share the information.
It wasn't me, it was my mother, but I can.
Okay.
I just feel like it as well.
If you want, we may try to do something about like a journal club, so more or less. If you want to send to us the paper. Other questions, guys?
There is a question written by Jonathan in the chat.
Sure.
Would it be anthracycline toxicity, in the left ventricular?
I don't listen very well, Alessia.
Would it be anthracycline toxicity?
If a toxic can induce this kind of modification in the myocardium, that's
I think John is asking whether it could be chemotherapy.
Chemotherapy. Okay. Like doxorubicin.
Doxorubicin, yes,
Exactly,
confirms.
Okay, that's a very nice question, because toxic induce degenerative process and necrosis usually. And so what do we see in the histological examination in this case? It depends from the timing, because in the beginning of the toxic effect we see degeneration, not so specific, maybe vacuolar degeneration of the sarcoplasm and necrosis. That's in the beginning. In the late stage, we have the effect of the necrosis. And the effect of necrosis is fibrosis. That's the scheme. All the toxic induce, many toxic can induce degenerative process and necrosis. It's not a specific, typical or specific reaction of the myocardium. But it is not the case that much of the information arrive from the experimental investigation, because they use the toxic, they kill the animal, and then they study the myocardium. But in the clinical situation, sometimes it's not so easy to put the link between the toxic and the effect. Usually, for the doxorubicin is different. I tried in the past to study the oncocardiology or cardio-oncology, because in a human there are specific specialists that study the effect of the chemotherapy in case of cancer in the heart. And so there are many information. But for us, the colleague said to me, we are not, the cardiologist said to me, we are not cardiac effect because the use of the chemotherapy. That's my point of view. I don't know your experience, but I like to listen your experience about.
Yeah, we were trying to do a paper for many years actually in Liverpool about the effect of epirubicin and doxorubicin. The truth is that it seems like we don't have the result yet, but it seems like unless the dog is a breed predisposed to DCM, they don't usually have a lot of problems, at least from what we can see echocardiographically, obviously.
Okay.
Yeah, but we don't do histo or gross pathology for those cases.
Because, of course, in a clinical scenario, histology is possible with the endomyocardial biopsy, and so that the human use. In the human medicine for to investigation the myocardium, they use the endomyocardial biopsy, of course, from the right side, the septum better. And otherwise, I don't know.
I think the other thing is that in dogs, it's difficult that you reach a very high dose of this chemotherapy.
Yeah.
So maybe that's the reason why they don't get a lot of problem with the heart.
Maybe because in human we know they use a very close to the toxic dose of the chemotherapy.
Yeah. But no, human is a big thing, and it's very interesting because, as you say, there is a full branch in human. There is the cardio-oncology, which is very interesting. Yeah.
There is a specific area.
I follow them on Twitter. They're very clever.
Yeah. I tried in the past to study this case, but colleagues told to me, "Oh, we have no problem with the chemotherapy." So if there is no problem for the clinician, there is no problem for me.
Well, definitely they see. Well, you can see a lot of ECG variation. During the actual therapy, but as I say, from the DCM or systolic dysfunction point of view, it doesn't look like to be a big thing, but there are some that obviously are probably more predisposed. But yeah, it's interesting.
Yeah, but I agree with you. If we have a breed or a subject with a predisposing situation for DCM and you use the chemotherapy, the effect is much more severe because you start with a vulnerable myocardium.
Yeah.
That's a predisposing factor, of course, I agree. Anyway, I think it's very interesting. Other experience, because
Massimiliano, Jonathan wrote on the chat a reference on doxorubicin toxicity.
In dog?
I think in dog. Is it in dog, Jonathan, if you can write?
Can you hear me?
Sure.
Okay, yes, we can hear.
Yeah, so this is a paper in dogs that's recently been published with microRNA and doxorubicin toxicity with some histology, and they showed that you've got this fatty infiltration as well within the left ventricle also, which looks similar to me. So maybe you can have a look and let us know what you think about the descriptions they provided.
Yeah, I have to check. But there is also a negative control?
I have to double check. I think it's a very small study with a couple of dogs. So it's mainly to look at microRNA. But they've got some histological changes so I can check if there is control dogs.
Okay, thank you. We have a lot of interesting focus. We need to study more cases. Okay, thank you. Other question? Oh, that's interesting. I love this situation. who want to try gross and histo, 10 case.
I can try.
Sure, Fabio.
So on the gross one, so on the gross one we have. I just want to try to understand if I can see if it's a left. It looks like an aorta. Oh yes, it is an
Sure.
aorta because there is a coronary sinus as well there.
Sure. Sorry, Fabio. We are looking for.
Oh, sorry. So this is a view of the left ventricular outflow tract.
That's correct. I like it.
Actually, I can see the septal leaflet of the mitral valve on the left part of the picture. Yeah, and then there is and then also on the right side, I can see the cusp of the aortic valve and the coronary sinus. I think just below, so ventral to the non-coronary cusp, I can see there is a communication, which I guess is.
I'm sorry, Fabio. Allora,
Yeah.
this portion, as I showed yesterday, is between the right coronary cusp and the non-coronary cusp, because that's the left, right, and non-coronary.
Okay.
And so this area is between the right coronary and non-coronary.
So yeah, it looks like there is a communication between the left ventricle and I guess the right ventricle.
That's correct.
If you can hear two kids screaming, that's just my kids playing. Okay, I don't know. There is a more they need to describe.
Okay. Which is the diagnosis?
So that would be a ventricular septal defect, perimembranous maybe.
Membranous, perimembranous. Yeah, I agree. Because here there is a small triangle area, whitish.
Yeah.
And that's the membranous, but it looks also around. So sometimes it's not easy to say only membranous. For me, it is membranous and perimembranous, because there is also an involvement of the myocardial component around. So it's not small.
Yeah, no, it's quite large actually. Yeah. Okay. And is there anything else they need to describe on this picture, I think?
For the macro, no, for me it's enough. Of course, take care because around there is some kind of whitish thickening irregular. They are all jet impact proliferation. That's for the turbulence of the blood, of course.
Okay. From the histopathology, I think is a lung.
I agree with you.
Good.
Why it's lung?
Well, I can see the alveolar and the endothelial of the alveolar surrounding it.
Yeah. Not endothelial, epithelial.
Sorry, the epithelial. Yeah.
Yeah. And that's the alveolar. That's a part of a bronchus here.
Okay.
Also here. But in the histo picture, what is the focus?
Yeah, I think there is a rounded area. I can't really increase the size of this picture anymore than this. But it looks like it's a rounded area with possibly thick wall.
Yeah. In the middle, there is a small cavity.
Yeah, there is a very small cavity.
Try to put a link. Between macro and histo.
I can't
Okay,
remember now.
Fabio, sorry, in the lung,
Yeah.
if you think about the histological structure, we have, of course, empty space, in alveolar, bronchus, small part of interstitium here. These small tubular are the glandular component close to the bronchus. Everything is normal. But in general, what we see also in the lung, very important for function.
Like a structure that is in the lung? Oh, the arteries, sorry, yeah.
Okay, the vessel.
Okay. Yeah, I was thinking like I because it looks like picture that I've seen of a plexiform lesion.
It's not a plexiform lesion.
Okay.
If you say plexiform degeneration lesion pattern and such, you have to think about this kind of functional modification. What induces this kind of vascular remodeling?
I thought it was pulmonary hypertension.
Sure. Pulmonary hypertension. But that's not a plexiform. Plexiform is with multifocal dilatation of the wall. That's a different pattern. I mean, you may to say, for your point of view, for the examination, eventually there is a severe thickening of the wall.
Yeah.
For me, it's enough. But you may to say also there is a severe medium and intimal proliferation.
Okay.
That's better. But basically, there is a severe thickening of the wall. And if there is a malformation, you know the pathogenesis, so it's the shunt from the left from the left to the right. There is an over circulation.
Of the pulmonary circulation,
Circulation, and which type of pulmonary hypertension could be this case? There are a lot complicated, but it was the first type, also in human, in 15 years, 15 years more or less. In case of shunt communication between the left and the right, type 1.
Type 1, yeah.
Type 1. That's the most common. For us, could be also secondary to the left side disorder, maybe because valvular insufficiency, hypertrophy, and such, like a hemodynamic model.
Mm-hmm.
Okay?
Yeah.
It could be. In your presentation, in your examination.
Yeah, no, definitely. I was thinking whether you have a picture of the plexiform lesion as well.
Yeah, I have some picture about plexiform degeneration. But in plexiform, I think that the plexiform for you could be more difficult for the interpretation.
Yeah,
I think that I think that maybe for you it's better to see a wall with a severe thickening. Because
because it looks like there is like layers around it. So it looks like
yeah. But also because for the pathogenesis, plexiform degeneration is the late stage.
Okay.
But anyway, that's a particular question about histology. Other question? Everything is clear? Do you have experience about pulmonary hypertension? Do you have experience about...
You would say here some media and intimal thickening hypertrophy, but obviously it's kind of occluded as well, the bronchi, you know. So we might not be at the stage of the plexiform lesion, but you can imagine that if you let this process going forward, we will end up with a plexiform lesion. Is that correct?
Yeah, I agree.
And then eventually necrotizing arteritis or something like that.
Sure. That's the problem for the wall is the mechanical depression, eventually the volume, because there is something too similar between the cavity of the heart, maybe a ventricle, and the wall of the vessel. Because in both situations, we may to have pressure overload or a volume overload, or both. And this kind of alteration induce mechanical remodeling, chronically speaking. And so we are also at the moment of the stage also necrosis, sure.
Massimiliano, can I ask you a question? On that artery, I know that if I was in an exam situation, I would definitely would say medial, and I would say also intimal, because I know also the intima gets thickened. But can you really differentiate between the intima and the medial layer on that picture, or is it impossible to differentiate both layers?
It's not so easy. It's not so easy because
and the muscular layer is quite thin in that it's much thinner, isn't it? Is that one? Yeah. Okay.
Yeah.
Okay. Perfect.
So
thank you. That's all. Thank you.
If you say for your examination, if you say medio-intimal, you are right. You are right, because with other pathologies we made to discuss for 1 week about this picture. For some pathologies could be just intimal, medial, not so much. So that it's for you. If you say medio-intimal, is it correct for me?
If we say medial and intima, that's fine.
Yeah.
Okay, thank you.
Almost finished. Alessia, we have time for another one?
Oh, okay, Massimiliano, it's 12 o'clock. As you prefer, I was just writing you a text message about it. And as you prefer, for me, there is no problem.
Okay, I can suggest just this case, and then we have a lunch. We see at 2 o'clock for the mock examination. But before to finish, Alessia need the time for. Do you want now or when I finish this picture, Alessia, at the ending?
As you prefer. It is just a tech communication. So finish the case, please.
Okay. That's the last picture, the last case before the mock examination. For the mock examination, you will see, I don't remember, maybe 10, 11, I don't remember, a picture. You are 3 minutes for every picture, and you have to write on your table the answer, and when we finish, you have time to discuss together. Okay? Everything is clear for the mock exam?
Yeah.
Perfect.
Yeah.
So what about this case?
I can try if that's okay.
Yeah. For me, it's okay. If it's for you, it's okay. For me, it's okay.
Yeah, unless someone wants to step in, but I'm happy to go ahead. Thanks. So this is a transversal section of the heart at the level of the palpebral muscle on the left, and we can see I believe, some on the right hand side.
Sorry, but I lose your voice.
And we've got other section of this myocardium that looks like probably something, I would say, maybe a wall.
No, take care. That's the heart, of course, but the other are not the heart.
Oh, okay. All right, let me think about what that can be.
I'm sorry, there is my daughter.
That's fine. Say hello.
Okay. I'm sorry, do you recognize this organ? Because that's the contralateral with a lesion, but that's normal.
Well, is that an adrenal?
Again?
Could it be an adrenal? It looks big, though. I don't know. Adrenal gland?
Adrenal gland. No, adrenal gland, you have to see cortical and medulla.
Yeah, well, that's just because it was kind of not very peanut, but...
No. Here there is not a pattern of cortical and medulla. Look here, that's an organ, and that's another organ. Very close, very close. They stay in the neck.
Oh, the parathyroid, the thyroid?
That's the parathyroid, and that's the thyroid. That's the parathyroid of the opposite. That's the capsation. And look here.
Yeah. So they are so obviously a normal thyroid gland with a parathyroid, and in the middle and on the left, we can appreciate so two glands that are abnormal and heterogeneous. So that's look thickened compared to the normal ones. We can appreciate that there is a tissue that is whitish and slightly heterogeneous, replacing the normal tissue.
Sorry. Use the keywords. What is?
Well, the thyroid gland, it looks heterogeneous and with a whitish discoloration.
Why there is this kind of discoloration? Why there is
because of a neoplastic process?
Sure, right. That's the nodule.
Yeah. So that's two thyroid nodules.
Oh, take care, because this one is the same thyroid gland. I cut in the middle. That's normal. But this one, at the external examination, there was an enlargement. And so I cut in the middle, and so I can appreciate the nodule.
Okay. Sorry, I thought it was two, you compared with the normal, and you had the two ones from the cut.
Yeah.
So enlarged thyroid with a nodule within the thyroid. And obviously, if I have to correlate this to the left and the gross pathology, so we can see there is probably thyroidotoxicosis, so with moderate hypertrophy of the left ventricle, which is symmetrical. So involving the interventricular septum and the free wall, maybe a little bit more the free wall actually. So
take care, because for the free wall, don't use the papillary muscle.
Papillary muscle, yeah. So it's symmetrical here. I think there is nothing, Otherwise, I cannot see anything else. I think this pinpoint reddish lesion are probably something artifactual.
Ah, that's an artifact. Sure.
Yeah, and also on the right, you've got this like little dot, red dot.
Yeah.
No, a little bit above on the free wall.
Here.
No.
Oh, here. Here.
No. Down. On the
Here?
right.
Here.
On the right. Yeah.
Yeah. Artifact.
Okay.
But I think that more or less we are 5, 7 millimeters in the thickness. Actually, is a very mild, moderate hypertrophy.